not done so, please put your name and contact information into chat. It just helps us know who's on the screen on the call. And as you know, that we are recording today's session. We store those on our Canvas page. It's a way to go back and review any of the information, or as well as just share it with colleagues. If you'll take a minute and rename your profile with your name and where you work or your discipline, that again just gives us all who is on the call, so that we know who's joining us, where you guys are from, to be able for us to reach out to each other if we have any questions. Zoom does have, we want this to be interactive, so you can raise your hand, or you can also just come off mute or put it into the chat, and we'll get to you on that. But here's how to raise your hand in case you don't know how to do that. In all of our ECHO sessions, we do talk about confidential information. So remember to protect individual privacy. Don't share their first and last names, their mother's maiden name, or their social security number. That's what we want to avoid. If you have any questions, please reach out to any hub members. We all have an asterisk in front of our name, and they'll be able to answer any questions for you. ECHO is a participation interactive community, so we want to have those questions. We want to gain everybody's feedback and information. So please remember to, and if you can, turn on your cameras, answer questions in chat, raise your hand, ask the questions. Some of these cases are pretty tough that we are working with, and we have a great group of individuals on here that have tons of experience. So ask that question. Case narratives are a great way to gain information. So if you've not done that, I know it's always scary to get up and present a case that you're working on, but you guys all know that we come up with some great resources and suggestions in our breakout sessions. So if you're interested in doing a case narrative, please submit one. It's, like I said, just a great way to learn from your colleagues. If you are new and have never joined an ECHO session before, there's some community components of our ECHO sessions. We are trying to create a community of practice so that we know who to reach out to. I could be like that Tiffany shared a great resource and I want to follow up with her. So I need to know what her name is and where she's from. We always have a didactic speaker. I'm thrilled today to have Jamie Mecham from the communication department here at USU speak with us today. And then we do have a case presentation where we offer some feedback. So those are the components of an ECHO session. Again, just another plug for those case presentations. They are a great way to hear from your colleagues and get recommendations on cases that we're working on. We offer a certificate of attendance by completing the survey. We will be putting the survey link in the chat throughout the session. So if you'll take a minute to complete that survey, it's a way that we can keep these sessions free. We're able to take that information and share it with key stakeholders. So thank you always for filling those out. It provides valuable resources and information for us. It will also be sent to you in the post email. So if you didn't fill it out during the session, you can fill it out during that time. Canvas is where we store all of our information. So if you've not accessed our Canvas site, you can email Project Scope at USU to request instructions on how to register for that Canvas page. It's where we store our PowerPoints, information that presenters give us, as well as any information that is shared during our breakout sessions and handouts that are shared during that time. We also have our social media accounts where we talk about our sessions, but we also have valuable resources that are shared on there. So if you want to follow us on any of those social media, you can just scan that QR code and it will take you to our pages. As I said, I'm really thrilled that Jamie Mecham is willing to share with us again about trauma and language development. It's just a great resource, and she provides tons of useful information about how that language development happens. Our next session will be June 14th, where we will be talking about self-regulation and trauma. So if you've not registered for that session, please take a minute and do that after the session. I'm going to stop sharing and turn the time over to Jamie so she can take it away.
All right. Hello, everyone. Like Janelle said, my name is Jamie Mecham, and I am a speech language pathologist and the clinic director at the Utah State University Speech and Language Clinic. Please, if you have questions throughout the presentation, don't be afraid to interrupt, raise your hand, put it in the chat. Janelle, if you guys have watched the chat, and let me know if there's questions. I'm happy to answer them.
Yep, I will do that
as we go along. We are talking today about language outcomes and trauma. And our learning outcomes are to identify common impairments in speech, language, and social communication to better understand language development, and especially language development in prenatally and postnatally exposed, abused, and/or neglected children, and to learn some effective intervention. Some of today's content may be really difficult to hear, so if you're feeling triggered by the topic or the presentation, please feel free to take care of yourself. One thing I've learned, particularly in the last few years, as we have seen a lot more clients that have dealt with really traumatic experiences, is that we cannot care for our clients or our patients if we don't take care of ourselves. Trauma in children is what we are going to talk about today. Trauma is defined as an overwhelming event that renders a child helpless. It's important to realize, though, that traumatic experiences happen throughout the lifespan and impact different people differently, and that trauma can also happen to a child prenatally. There are many different types of trauma. There's maltreatment, which is considered abuse of any kind, physical, sexual, or emotional, and neglect. In 2019, there were 656,243 substantiated cases of maltreatment of children, which really makes me question and wonder how many unsubstantiated cases were there. State-sanctioned violence is considered a type of trauma, which can include exploitation, impoverishment, police violence, slavery, and human trafficking. Consequences of migration, including migrating under duress, or ethnic and racial violence, disasters, gang violence, racism, and other forms of systematic inclusion, including isolation or bullying, and adverse childhood experiences, which are events or experiences that happen in a child's life, which can cause trauma and can include any of these: abuse, neglect, losing a parent, divorce of parents, death, exposure to violence, mental illness, drug or alcohol use by a parent, or an incarcerated parent. Complex trauma is trauma that happens within the caregiving or the family system. Our homes and our families are supposed to be the safest source of stability and strength, but when chronic negative interactions occur, it causes trauma. Complex trauma can also occur prenatally when a mother is exposed to chronic stress or participates in activities or behaviors that can endanger themselves or the fetus. It will impact development and is considered complex. Complex traumas impact a child's ability to form secure attachment bonds. Recent research shows that 46% of children in the United States have experienced at least one adverse childhood experience, and 20% of children in the US have had at least two. So we're talking, greater than 50% of the population of the children that we work with. So you will see these kids in your practice. You will deal with families who have been exposed to tremendous amounts of trauma. And so it's important to understand what the impact of that is. We don't have time to do this, but if you have a pen, write down this TED Talk and watch it. It's like 15 minutes long, and it's so enlightening. It's called How Childhood Trauma Affects Health Across a Lifetime by Dr. Nadine Burke-Harris. We're talking today about the way trauma impacts language, but the effects that trauma can have over a lifetime, it's mind-boggling. And Dr. Harris has done a lot of research and has a lot of information out there about trauma. This was one of my favorite talks she gave. So there's stress, and then there's toxic stress. Trauma causes stress, but toxic stress can permanently alter our brain and language development. Our biological stress response is designed to save our lives from something threatening, and that's really healthy. But the problem is that when the stress response is activated repeatedly, it can become overactive and affect our brain's development, our immune system, even how our DNA is read and transcribed. High doses of stress hormones inhibit the brain's executive functioning, and they make it harder for kids or adults to exercise impulse control and learn the language that they need in order to communicate in their environment. MRI images of trauma survivors show a shrinking of the hippocampus, which is the brain area that's important for memory and emotional regulation. And they show increased sizes of the amygdala, which is the brain's fear center. So trauma and stress can make you hypervigilant and oversensitive to threats or challenges. So individuals who are exposed to high doses of adversity in childhood, the pleasure and reward center of their brain is affected, and the amygdala begins to kind of act as the accelerator. It takes over, and the prefrontal cortex, which is responsible for language use and language acquisition, is told to break because it needs to protect itself. And in order to protect itself, the amygdala takes over. And therefore, you see just the shrinking of that part of the brain where kids learn to talk, where they learn to process and store and understand and use language. So just as an overview, there's a growing body of evidence that demonstrates that trauma exposure affects children's communication development. Early research shows that children who had experienced maltreatment had significantly poorer speech and language abilities in terms of receptive, expressive, and pragmatic language skills when compared to those who had not experienced maltreatment. Research demonstrates that early deprivation and trauma result in lifelong neurological changes that impact all aspects of health and development. Basically, that part of the brain that learns language is shut down in order to protect, and that stress response is what the children are responding to. As we continue to talk about the effects of trauma on language development, I just want you to keep in mind a family. This is a family that we've recently seen in several clinics at the USU Sorensen Center for Clinical Excellence. At this point, and it's been a year in the making, we have assessed all 6 of the children for speech and language delays. Mom has disclosed years of family trauma, including abuse. The children have not had access to adequate health care, They don't attend public school. They've had no social networks outside of the home. In the past year, all 6 children have been diagnosed with PTSD. 3 have been diagnosed with severe hearing impairments. 4 have been diagnosed with severe expressive, receptive, and social language delays. And 1 has been diagnosed with a phonological impairment. All 6 children stutter when traumatic events are brought up. The last year is the first time these children have interacted with adults outside of their home. It's the first time they've seen a pediatrician or any kind of health care provider, and that includes prenatal care or care following birth. Children who are exposed to trauma prenatally, it could be through drugs, alcohol, maternal abuse and neglect, or just chronic stress for the mother, have low gestational age and low birth weight. There's neurophysiological changes, neurobehavioral development is slowed, and they have delayed language development. So thinking about the case study family, by the time all 6 of those children were born, they had been exposed to complex trauma. One of the most important and conclusive aspects of language development is the attachment bond between children and their primary caregivers. This begins in the womb and is strengthened as the child has strong attachment interactions with the caregiver. Complex trauma interferes with the child's and the caregiver's ability to build a strong attachment, and therefore interferes with their ability to develop language. Signs of trauma in very young children: they cry and scream more than typical. They could be timid. They could develop new fears and anxieties, have nightmares, wet the bed, have poor eating habits and weight loss. Sometimes they use baby talk or revert back to baby talk. They like to recreate the traumatic experiences during play because it's the only way that they know how to express and communicate what's happened to them. And they'll have stunted developmental growth. Research has shown that caregiver responsiveness to their child and the nature and complexity of the language they use while interacting with their child has a significant impact on language development. A primary caregiver plays an important role in communication development, when a child's communication skills are learned through back and forth interactions with the caregiver. When there's been trauma in the context of this relationship, it directly impacts language acquisition. It impacts the child and the caregiver's ability to bond and to learn how to communicate little things. Moms who aren't experiencing stress or trauma can tell what kind of cry their baby's having. Oh, that cry means they're hungry, or that cry means they need a diaper change, or that cry means they just need to be held. When parents or caregivers are going through complex trauma, their brains are in fight or flight, and they can't take those signals that their child is giving to them and turn them into meaningful communication exchanges either. Signs of trauma in elementary age children: they feel shame or guilt. They have a lot of fear and anxiety. They're clingy with adults they can trust, have trouble sleeping, worry excessively, have difficulty concentrating, startle easily. They either repeatedly talk about the experiences or they refuse to talk about it at all. And there's usually a decline in school performance or loss of friends. They might be having memory difficulties. In the past few years, there's been a lot of research and a lot of systematic literature reviews that have gone into looking at what trauma does to language. They've all shown that there's more language concerns with children who have a traumatic past. They have difficulty with vocabulary, comprehension and production, problem solving, memory, sensory modulation, and pragmatics. Language and pragmatic delays are not exclusive to trauma. Every child that you see who has a language delay, that does not mean they've been through traumatic experiences. We don't always know the reason a child may have a language delay, but it's become evident in the literature that children who experience trauma have more language concerns than their peers. Trauma exposure has also been shown to negatively impact problem solving, memory, executive functioning, emotional regulation, intellectual functioning, which are all important to communication and overall development. As I've met this family that I talked about in the case study in the past year and have been really looking into trauma and language development, a year ago when I started this journey and Janelle first asked me to present, there was very little research out there. I found basically these 3 literature reviews. In a search that I did just this week, the literature has exploded. There's so much out there. There's so much research out there now that is linking trauma to a myriad of not only language delays, but health and educational delays as well. If we're going to identify an impairment, a language impairment in a child that we are going to, that we believe has had a traumatic experience or a traumatic past, children in preschool and up to 3 populations will show a very limited vocabulary. They'll have unpredictable behaviors. They may show a lot of frustration, may lash out really easily. There's an inability to follow directions and a difficulty making friends and connecting. As the children grow, you'll see decreased expressive vocabulary. So they may not have a typical mean length of utterance, meaning they may not use sentences or speak in complete sentences or have a sentence that's as complex as you think it should be for their age. They'll have low vocabulary. They won't be able to name objects. They'll use a lot of indescript vocabulary. This, I want this, or, you know the one I want, instead of actually naming what it is that they want. They'll have decreased receptive vocabulary. Their auditory comprehension will be low and they'll have difficulty following directions. One of the largest impacts in language is in just how limited and informative and cohesive their narratives are. They don't have expository language skills. They can't tell you a story. It makes it really difficult for them to express what's happened to them and make it believable, because they don't have the vocabulary, they don't have the cohesive language abilities to put it together. And they'll definitely have a lack of social skills and social competence and executive functioning. They're not learning about the world around them. They're just learning to survive. Children who have trauma backgrounds are often misdiagnosed because trauma responses can look like a lot of other disorders, particularly if you don't ask the right questions and get to know the family and the child's history. They're often misdiagnosed with ADHD or ADD, autism, oppositional defiant disorder, sensory integration dysfunction, learning disabilities. Going back to the case study family, when I first met them, mom was convinced that 4 of her 6 children were autistic. She had Googled the physical manifestations of the trauma that she was seeing, and the first thing that popped up on Google was autism, and so she was pretty sure that's what they had. In reality, not one of them was diagnosed with autism spectrum disorder. They were all diagnosed with speech and language impairments and PTSD. Often the physical manifestations and the symptoms look the same. It was really, really a hard conversation to have with a mom, where most parents, really don't want to hear that autism diagnosis. She was holding on to that and hoping that that could be the reason for her children's lack of development and behavioral outbursts, because that was easier than recognizing that it was caused by trauma and events that had surrounded their family. All told, trauma manifests itself in neurological changes, particularly in areas of the brain that are associated with language and cognitive development and emotional understanding and regulation. Ongoing deficits in recognizing emotions and linking emotions to contextual situations. Kiddos who have been exposed to trauma are less accurate in identifying positive emotions in facial photos. They're poorer at recognizing sadness. They definitely recognize anger. They perceive anger in ambiguous situations, and they have fewer and less detailed episodic memory. And this begins to show up as early as the late preschool years, where kids just can't tell you what happened at lunchtime, what happened at recess. They can't tell you why they're crying or why they're upset. The Substance Abuse and Mental Health Services Administration defines trauma-informed practice as practices that are based on the knowledge and understanding of trauma and its far-reaching implications. The need for interprofessional collaboration is especially essential when working with young children who have experienced multiple ACEs. We need to realize the widespread impact of trauma and recognize the signs and symptoms and respond by integrating that knowledge of trauma into practice. In order to do that, we really have to work together. We have to work as an interdisciplinary team. We have to understand that everyone that's working with this child and is spending time with this child can contribute. SLPs require knowledge of mental health workers have to understand the social, emotional, and behavioral aspects of trauma. Mental health workers need to be able to recognize the ways in which communication delays and disorders may be interrupting their mental health. Pediatricians need to understand and work with both mental health and communication specialists to understand what it looks like when they come to visit your office. Early educators, school teachers, we all have to work together. Because children who have experienced trauma are at risk for a variety of developmental delays and disorders, and most likely and most long-lasting being a communication disorder. And another aspect to think about and understand as you're dealing with the whole family is that mothers who experienced ACEs as young children and who had traumatic experiences of young children often have more difficulty in producing coherent narratives, reminiscing about their past, communicating, and that disrupts the bonds of attachment and result in their children's long-term difficulties in using language. So it's generational. If mom has a hard time expressing her feelings and regulating her behavior due to traumatic events in her past, those things are going to be passed on to her children. So what we really need to do is use trauma-informed practice as we treat children who have been exposed to traumatic events. What that looks like is probably different in every office and with every care provider, but the basic tenet is that we need to make sure that these children feel safe, that they recognize trust and transparency, that they're given opportunities to have peers and have peer support, that there's collaboration in their treatment, that everyone's working together to the best benefit of the child. We give the child empowerment. We give them a voice and a choice. Often kids who have been through traumatic experiences feel like their lives are very out of control. Nobody's asked them. They haven't asked them what they want, even something as simple as what they want for a snack or where they want to sit. So it's so important to give them a voice, to let them make choices. And it's also important for us to understand, the cultural, the historical, the gender issues that are impacting their family. It's important to know historically, if we're talking about generations of trauma, or if this was one, traumatic event that's just starting to impact the family. We need to change the question from what's wrong with this child to what happened to this child. Children don't act out. They don't, typically, it's not something that's wrong with them. Something has happened, that's causing their behavior to be different. Children learn what they live. If they're living in a traumatic situation, if they're constantly having traumatic experiences and stressful experiences at home, that's what they're going to learn. They develop at different rates. Some are more aware of their strengths and challenges than others. Their brain development's impacted by their well-being and their early attachment and stress. Some children are just more resilient than others based on positive experiences. So it's important to understand and know where the child's coming from, what kind of experiences they've had, and what's happened to the child. Trauma-informed practice and action is a team process. You'll do assessments that identify the child's strengths, and you'll complete evaluations and interventions like you would with any child, with an added layer of holistic understanding that you can't just treat the child. Trauma happens to the whole family dynamic. Multidisciplinary care, reducing adversity and treating symptoms using best practice, including home visits, care coordination, mental health counseling, nutrition, holistic practices, and sometimes even medication are vital to helping the child learn and grow. And educating the parents. Often the parents have been through the same traumatic events, or are experiencing the trauma themselves, or are the reason for the trauma, and they need to be educated to how their behavior is impacting their child and their child's ability to learn. Trauma-informed practice looks like creating a safe psychological and physical space, being consistent and transparent, having clear boundaries, being aware of possible triggers for the individual child, and listening to the child's voice and providing choices. Trauma-informed assessment, you will use standardized assessments, criterion referenced assessments, interviews, observations. In my opinion, the interviews and the observations are much more important than the standardized assessments. It's important to get to know your client and their family, get to know the caregivers, see the child in all different settings. Do interviews and observations at home and at preschool or at daycare or everywhere that the child interacts with people, so that you can see and get to know and understand the impact of the trauma and impact of development on the child in all different aspects and all different settings. We often will see parents or children, who say they're not talking at all at home. And then we'll talk to the preschool teacher who says, oh, well, we don't have that problem. They talk nonstop at school. So it's really important to get to know the client, get to know the family, get to know them in all different settings, so that you can really make an informed decision about assessment and intervention. Informed intervention, first of all, has to be safe You have to minimize the child's overwhelm. When you think about that children who've been through trauma just have a smaller prefrontal cortex, it's going to shut down a lot more quickly if they're feeling overwhelmed. So minimize the overwhelm. Remember to change your mind about behaviors and the way that the child's exhibiting their behaviors, and think about it in terms of what is the child trying to communicate to me, and then recognizing the trauma behaviors. Establishing clear boundaries. Children who have experienced trauma need a safe space and a safe person, but they need to understand the boundary. You won't be in their life forever. They will move on, they'll grow. They need to learn to form safe and secure attachments and recognize safe people in their environment. And so if you don't set boundaries, you risk re-traumatizing the child as the child moves on, maybe gets a new speech therapist, gets a new teacher, doesn't qualify for early intervention services anymore. You cannot be the only person in the child's life that provides that safe space. So you have to really be careful to have clear boundaries. And it's hard. It's really hard when you connect with a child and you can see their progress and their potential, to make sure that those boundaries stay clear. Provide choices rather than limitations. Make sure that your intervention is strengths-based, that you address any triggers that may come up, and that you're constantly supporting resiliency and addressing the skills that support self-sufficiency. A vital part of informed intervention is modeling and teaching parents, model for parents how to provide a language-rich environment. It doesn't come naturally to a lot of parents, particularly and especially if they have been traumatized. It's really easy if you're going through a lot of stress and feeling a lot of trauma in your life to zone out, to just stare at your phone, to not engage and interact with your child. So, if it's not coming naturally to the parent, we have to model for them. We have to teach them. We have to show them how to put their phone down, how to engage and interact, how to read predictable books, how to use wait time. We have to teach parents how to talk to their children and play with their children, teach them language stimulation techniques, using things like self-talk, talking about what you're doing. Look, mommy's making breakfast. We're going to have eggs. I'm cracking the egg into the pan. Or parallel talk, talking about what the child is doing. Oh, Johnny's pushing the truck. Expanding on what the child is saying. So if the child says dog, you might say, it's a big dog. We have to explicitly teach parents how to do these things when if it doesn't come naturally to them. I've had parents tell me, I don't talk to my kids until they can talk back. And if we're waiting to talk to our kids until they can talk back, they're not going to. And then we've lost vital years and vital experiences and vital attachments to help the child grow. Children learn by example, and it's never too young. Birth, start at birth, start prenatally, read to teach parents to read to their kids while they're still in the womb. It's never too young. Trauma-informed intervention also looks like remembering that relationships with caring adults can protect children from the ongoing effects of stress. Some things to remember when we're working with a little bit older preschool, school-age children is, we often use hand-over-hand instruction. Don't use hand-over-hand instruction with children who've been traumatized unless you ask for consent. Have them put their hand on top of yours. Have them feel like they're in control. Tell students the plans for your lessons or your visits. I like to tell my students, talk about the goals they're working on for the day. We occasionally review why it's important to work on the goal. Knowing what they're working on gives them buy-in, and it helps them to understand the process. For younger students, asking them if it's hard and recognizing that it's okay for something to be hard, and that what we're working on is going to help it to become easier. Also talking about that it's okay to feel frustrated when things are hard, when they're working on things that are difficult, and that they can self-advocate. They can advocate for themselves. For older students, it's important to have them help you set the goals and work together on what it is that they need to accomplish so that they can have buy-in. Overall, we need to use strategies that help students feel like their voices are being heard. It's important to be predictable. Kids of all ages are more comfortable when expectations are clear and consequences are predictable. Allowing them ample time for transitions, giving warning time when an activity is going to end or when the session is going to be over. Not basing rules on compliance. I like to think about rules in terms of we need to be safe and we need to be kind. If you need to have a child change their behavior, using it in relation to safety or kindness. So for example, if they're leaning back on their chair, bringing it up by saying, I need you to be safe. So you can either sit with your feet all the way on the floor, or you can stand up if you need to move around a little bit, because I don't want you to get hurt, versus you're breaking a rule, put your feet on the floor. They may not recognize that they're breaking rules. It's not an intentional thing. They just might need movement to keep regulated, or they're having a hard time sitting in their chair. So it's important to base rules not on compliance, but on helping the child to be safe and understand what's appropriate. It's important to recognize their emotions and let them feel their emotions. Sometimes, a child cries and we want them to quickly recover. Strong emotions might take a long time to recover from, and it's okay. Work with other professionals, work with counselors to see what would be most appropriate for the child who's experiencing a lot of emotion and feeling those emotions. It may mean that your goals and the things that you're working toward take longer, but it's important to recognize the emotion and let them feel the emotion. And it's important to be flexible. Sometimes you don't get done what you wanted to get done. You get to a home and the child's having a bad day and the parent's having a bad day. And maybe what they really need is just someone to listen. Maybe what they need is someone to show them what it means to read a book out loud. Maybe they need someone to show them how to hold the child, to give them the comfort that they need. Our sessions need to be flexible, and they need to be about the family, and they need to be about the child, and not about our goals and what we need to get done. I think flexibility in terms of what we try and teach our students as they're going into speech pathology, flexibility is the greatest lesson that we can give them, to be flexible and to do what the child needs, do what your client needs, and what their family needs. And that's how you're going to build the bonds and that are needed to make intervention effective. In terms of our case study family, the key to really assessing and treating this family has been open communication, empathy, and transdisciplinary care. Empathy is important. It's easy to not be empathetic when you realize that traumatic events have happened that could have been avoided. Sometimes traumatic events are based on someone's choices. Oftentimes they're based on someone's poor choices. But we have to show empathy and communicate. Transdisciplinary care has been vital. You can't treat clients who've been exposed to trauma in a silo. We have used social workers, audiologists, vocational counselors, speech language pathologists have all worked together to treat the entire family using a very holistic approach. It's the only way that you can make lasting change in the family system is by treating the whole family and doing it holistically with other disciplines. The other thing that we can do as professionals is to advocate, help colleagues change language and mindset about behaviors that are impacted by trauma, learn about the effects of trauma in all areas of a person's life and body, recognize when there's a need for a trauma assessment. Maybe you go in to do an assessment because all you think is, well, we've just got a speech and language delay, and you realize really quickly that there's more going on. Recognize when there's a need to get other people involved and do trauma-informed care. And always remember that children and adults can heal from trauma. They can get better. They can progress. They can make the necessary changes in their life to help themselves and their children, and they can learn. References. One thing I did want to tell you all about that is kind of exciting. A lot of what I've learned and what I've read has been based on work done by Dr. Yvette Heyer. She is coming to Utah State and speaking. I believe it's the second week of June. Her presentation is called Child Trauma, Social Pragmatic Communication and Trauma-Informed Care and Speech Language Practice. It's part of the Communication Disorders and Deaf Education Summer Seminars. It's available to anyone who works with children and or is interested in learning more about children and communication and trauma. So if you're interested in checking her out and actually hearing her speak, she will be here. There's the website you can go to if you're interested in signing up for the course. It is for CEU course CEU, so you can get a little bit of continuing education too and come and spend the day listening to her. Does anyone have any questions? Comments?
Jamie, just one question that I have for you. Anybody can sign up for this session, is that correct?
Yeah. I talked to Chad Bingham, who's in charge of summer seminars, and he said, absolutely, anyone from any discipline who's interested in learning more about trauma and communication is welcome to sign up and come in and listen to Dr. Heyer.
Great. We'll also share that on our social media resources if you're okay with that.
Yeah, that would be great.
Anybody have any questions for Jamie? It was a great presentation, Jamie. Thank you so much.
You're welcome. Thanks for having me. I think Janelle does have the slides. Oh, maybe.
Yep, we have the slides and we'll get those sent out to you.
Perfect.
Hey, well, if there's no other questions, I'm going to have Becky come off mute and share the case with us. All right, Becky.
Okay. Can you see the screen?
Yep.
Great. Okay, so how do I go back?
So you can hit the back arrow. There's a little button.
Oh, there it goes. Okay.
There you go.
It's just
Okay.
slow. Okay. Fantastic. I'll just hit it once. Okay, so the background. This was a little kid that we did an assessment on from up to 3. And we were sent the referral by the University of Utah. a NICU. So, this is a 2-month-old female. She was born at 35 weeks and 2 days, and it was a spontaneous delivery. So she just came early on her own. And there was opiate exposure in utero, the preterm birth, and then she did require medication for symptomatic withdrawal while she was in the NICU. So the birth mom, her prenatal history is very significant for active drug use during pregnancy. She was on heroin, marijuana, cocaine, nicotine, and other opiates. So she was prescribed methadone and an SSRI. The infant ended up being adopted during the hospital stay. The adoptive parents have 2 other children. One is biological and he's 8, diagnosed with ASD. One is adopted, he is 4, and then also has an NAS diagnosis and is a little bit difficult. And then the adoptive mom is pregnant. The adoptive parents have worked with early intervention in the past for both their older children. So they have experienced with autism specialists, speech language pathologists, occupational therapists, physical therapists, and behavioral therapists. So the primary area of concern is that this infant has significant irritability, high tone, and she struggles coming to a quiet alert state. She's very difficult to console and is not sleeping well at all. And she has a very hard time self-regulating. Feeding is also something that is very concerning. She seems to still have trouble with her suck, swallow, and breathe. While she is feeding, adoptive mom will hear choking and gagging. She starts to shut down while she is feeding, and then she will arch away from the nipple. She has turned dusty 3 times, and formula will come out of her nose and her mouth. She's on famotidine for reflux, and then she is getting Nutramigen mixed to 24 calories through a preemie nipple, and she will only take 1.5 to 2 ounces every 3 hours. Some of the goals are improved eating, longer periods of sleep, and then increased consolability. Barriers, so after discharge, she is very difficult to console, needs to be held to sleep, and only sleeps up to 1 hour because it takes an hour to feed her, an hour to console her, and then she only has 1 hour to sleep before it's time to feed her again. She seems like she's in pain while she's eating and after she's feeding. So that is a big concern. The Nutramigen is difficult to find and is also expensive. They do have WIC, which is helpful. At the USU hospital, they use the ESD to decide how to eat, sleep, and console her, but adoptive mom was not taught which cues to watch for or how to help console her. Some additional information is that mom and dad will only be able to take turns while they are with the infant. One will sleep while the other one's holding, and so they're out most of the night. Birth mom was on bed rest. She is currently pregnant until December, and then they adopted this baby in January. She was in the NICU for 12 days, received the morphine for her withdrawals, and the ESD scoring was used during her stay. And on her day that she was supposed to go home, they decided she was not consolable enough, and so they gave her 1 extra dose of morphine, and then she was discharged the next day. She is receiving services from up to 3 with our occupational therapist, nutritionist, and developmental specialist. So if we can get your help, the things we'd like to see if you have some ideas on are any ideas to help parents learn how to console her or what they can do, how to help her come to a quiet alert state, to help her have increased sleep and begin to self-regulate. And then suggestions for feeding to reduce her choking, gagging, and arching, and then what they can do to increase the amount of feeds without causing increased pain, difficulty, or an aversion to feeding. And so we were thinking probably splitting up into 2 groups, and then if everybody could just if they have any resources or anything they've been able to find formula during the supply shortages, that would be awesome.
Great. Thank you so much, Becky. So we are going to go ahead and put for everybody into groups. And Bailey, who's in charge of group number 1?
So Tiffany Warwood and Natalie Allen. are
So
the two I
Tiffany
have.
and Natalie, you guys are going to talk about within your group ideas to help the infant to console, come to a quiet, alert state and calm so that she can have increased sleep and begin to self-regulate. And then who is in group number 2?
Kurt and Tiffany Anderson and Becky.
So Kurt and Tiffany, you guys will be doing suggestions for feeding to reduce choking, gagging, and arching. And what can mom do to increase the amount of feeds without causing increased feeding difficulty aversions? And if all of you will think about resources for finding formula during supply shortages. And then we will move Becky between those 2 breakout groups. So Bailey, if you want to put us all into a breakout group, except Pat has a question. I saw that, Pat.
Why is she on Nutramigen? You're unmuted.
She started on Neosure, but I just followed up with the mom yesterday, and they had switched her to Nutramigen, which she said was helping a little bit. But I am not sure of the exact reason that they put her on the Nutramigen.
Okay, because it's not technically a very nutritious formula, and it is hard to get.
Okay. Thank you.
Okay, let's go ahead and do our breakout groups, and you guys have your questions. And
Hey, those are open, so you should see an invite to join, and if not, let me know.
all right. Anybody have one idea that they want to share that we talked about in the breakout groups?
I can share one. One of the things that we talked about, that my daughter had many of the same issues. We struggled with her in almost all the same ways. But one of the things that was the most beneficial that we talked about was swaddling. And not just, like learning how to do it right and swaddling as tight as we could. She responded to being just tight. And we had a specific way that we learned with my son when he was in the NICU, my first son, like they taught us exactly how they would do it. And it was like gold. I mean, we still had to hold her all the time. I was like yoga master swinging, like I was crazy. People would look at me like I was going to kill my baby. But that was one of the biggest ways that our daughter was able to calm down, was just to be as tightly swaddled as possible.
That's a great idea. Thank you for sharing. Kurt, anything from your guys' group?
A lot of good ideas. We figured with our part of it with regard to the spitting up and the pain and the arching and that it could be related to the type of formula that they're having. Could be related to reflux and the medications that what medications are going to help with that reflux. Becky took some notes in our group when she was there. We did talk a lot about swaddling and other ways that we can kind of help calm as well at the end. But Becky'd probably be a better one to share that first part of our.
Well, great. So if everybody will send each group will send their recommendations into Project Scope at USU.edu. We will get those compiled and send off to you, Becky. They will also be stored. The recommendations are always stored on the Canvas site. So if you want to hear all these recommendations, you can check those out too. Our next session, like I said, is going to be June 14th. Had to look at my calendar because I can't believe it's going to be June already, where we will be talking about self-regulation and trauma. So we hope to see you then. Everybody have a great day and please take the survey. Thank you.